joining us. I would like to invite Dr. Tashi Dendop. He's the Program Development and Operations Director from Save the Children, on the stage to give the opening remarks. And while Dr. Tashi makes his way on the stage, I would also like to request the panelists to be on the stage already, so it'll be easier for the live streaming now. Thank you.
Good afternoon, all. It's a great pleasure for me to welcome each and every one of you to the 66th session of Bhutan Dialogues. Honorable President, Dean of Faculty of Nursing and Public Health, faculty members, dear students of Gesegebo University of Medical Sciences of Bhutan. My name is Tashi Dendop, and I'm the Program Development and Operations Director for Save the Children Bhutan office. We are currently collaborating with the Ministry of Health, the KGOMs, key population organizations, and other stakeholders in implementing a regional multi-country grant called the Sustainability of HIV Services for Key Populations in Southeast Asia program here in Bhutan. We call this program SKIPA in short. The SKIPA program aims to promote sustainable services for key populations such as sex workers, men who have sex with men, transgender people, and people who use drugs in the region at scale to stop HIV transmission and AIDS-related deaths. Our focus under this program is removing human rights and other related barriers for key populations in accessing HIV and other essential health services. We are therefore extremely delighted to be partnering with the KGOMs, the Bhutan Dialogues, and the Ministry of Health in organizing the 66th Bhutan Dialogue session themed key populations and barriers to access HIV and related health services. Our discussion today is an important one, particularly because it examines issues that disproportionately affect the vulnerable key population communities, many of whom are young individuals. It's about acquiring a deeper understanding of the challenges facing the key populations, such as absence of supportive environments, the rampant societal stigma and discrimination, and structural barriers to accessing services, to name a few. These issues, combined with the socioeconomic and biological factors, increases their risks of getting HIV and related health conditions and outcomes. Creating a supportive environment, in addition to other targeted interventions, can enable key populations to access essential health services, including HIV prevention and testing, which in turn will not only enable key population community friends to live healthy lives, but also contribute to the prevention and control of HIV. Establishing a supportive health system for key populations, hence, is imperative in the context of HIV prevention and control. Today's discussion will feature esteemed speakers who will dive deeper into these crucial topics. I would like to express our sincere gratitude to Bhutan Dialogues, KGOMs, the National HIV/AIDS Control Program, for their support in organizing this event. Let us participate in this discussion with open minds and a shared commitment in promoting equitable health for all. Thank you everyone for being with us. Tashidilek. The floor is now yours, Naon.
Yes, thank you, Director. Kuzambola, hello everyone. My name is Ngaong Gelsin. I'm a tech entrepreneur. As for my non-profit endeavors, I serve as a trustee for the Loden Foundation, and Bhutan Dialogues is an initiative of the foundation. Bhutan Dialogues, just to give a brief description, is a forum for mindful listening and right speech. So I'd like to request the panelists, we will do our best with, they will do their best with right speech, and the audience, I'd like to request, please contribute with mindful listening. And when we break for question and answer session, the roles will reverse. The theme for this session is key populations and barrier to access HIV and related health services. The first Bhutanese to be trained as a fully graduate doctor, I believe, returned in 1954, and we built our first hospital in 1956. We've come a long way. In 2023, I think from January to June, we saw 26 new HIV cases. The same time, in 2022, we saw 40 new cases. I think it's imperative that we focus on the key population that, and we can't leave them behind. As a tech entrepreneur, I understand the importance of building ecosystem, and there is a saying, as is in military, I think we can't leave anyone behind. So I think this particular session, the reason why I'm extremely excited for this is because it's an endeavor to make sure we don't leave anyone behind. With that very long introduction description, we have, as director mentioned, we have some very esteemed panelists with us here today. Tenzin Gelson, he is the executive director and founder of Pride Bhutan. We have Dr. Pandit Siring, Professor, Gesigalpo University of Medical Sciences, and our former health secretary. And we also have Dr. Karma Sherap, Deputy Dean, Academic Affairs, Faculty of Postgraduate Medicine. And without further ado, my first question is to Tenzin. Tenzin, Pride Bhutan has been a key player in advocating for the rights of Sogi SC, right? Sexual orientation, gender identity expression, and sex characteristics communities. Now, as a key player in in the country, what are some of the major challenges that key populations face in accessing HIV and other health-related services?
Thank you for the question. So I think first of all, just to push my agenda, the registration status of Pride Bhutan would be the first that I would say, because since Pride Bhutan usually does so much work but is not recognized or registered as a civil society organization, I think there are so many limitations, but I believe that we can do much more. Right now, if you look at Pride Bhutan, how Pride Bhutan works, we are just limited to service delivery, such as testing, providing condoms and lubricants. That is one barrier that I see. The second one would be stigma and discrimination. I think since we are looking about or talking about key population, I think stigma, especially including self-stigma, would be one of the biggest challenge. And then I think lack of access to information on or awareness on what services are available in the health facility and where to go, whom to contact, is one of the third barrier that I see. And I think the fourth would be that we have not been able to address the needs of each key population, because when you deal with key populations, let's say we have LGBT, we have sex workers, we have people living with HIV, we have people who use drug and alcohol, and people who use drug and inject drug. So we have a very diverse populations. When you look at LGBT itself, you have a very diverse population within themselves. We have lesbian, gay, bisexual, transgender, intersex, and each population has their own needs, and I mean, they have their own issues. I think that is one thing that we have never been able to work on. I think we really need to focus. I mean, really need to work on to look at the different issues that each key population faces, and then tailor our services according to their needs and wants.
Plus, I have a follow-up question, Denzin. So, you mentioned 4 reasons, right? Or 4 challenges. Legal status being the
Yes.
first one. The other 3 challenges I understand are in implementation level. So I think your organization is doing an incredible work, awareness creation, and access to service. But there, so when you come about, directing the key populations, now legal status, what do you mean? How will you are already doing an incredible work? How will that sort of help your cause more? Just to briefly explain.
I think when it comes to LGBT, let's say fundings, you look at it is more of health-based or disease-based. So you see there are lots of omissions. Let's say trans men, where in other countries transgender men people are not usually involved because they are in low risk of getting HIV. And then when it comes to legal status, I think when you talk about HIV, it's not just about disease. It has lots of aspects to it. So we are talking about economic aspects, legal, social. I think since we are not registered, we are not able to mobilize resources to focus on other aspects of, HIV.
Lasla. So mobilization of resources is a challenge with the legal status key, because you're already doing a lot of work when it comes to implementing the strategy, right? So okay, thank you for the clarification. I'll move to the next panelist, Dr. Bandhu. With your extensive experience in public health and health governance, Tenzin here mentioned 4 causes for that inhibit his organization. Now, how do you see national strategies with regard to health service delivery and primary healthcare management address the unique needs of the key population? So he's the boots on the ground, but as you know, as leaders, making sure that the strategy is relevant. How is the please make sense the strategy for us, like decode it for us, and are there any gaps that need to be filled?
Hello, thank you for the question. Now, I think coming to these policy strategies regarding the service delivery, I think first, I would like to quote our constitution. So our constitution mandates that free health services, at least basic healthcare services, free to our population.
Yes.
So I think that mandate requires the Ministry of Health or the Royal Government of Bhutan to provide free access to basic health services. So that implies to our general public as well as to the key population. That means at least when you have free basic health services and all the services that our key population requires are within the listed within the basic health services. So that gives lots of financial risk protection to our key population. So that is, I think, especially now in this rising healthcare cost, I think this is a big financial support, financial risk protection for the key population. Now, after that, coming down to the health policy, if you look at the health policy 2010, I think. Now, first, health policy talks about providing access to health services to hard-to-reach, vulnerable population. So I think KP, key population groups fits into that. And the health policy further also mandates, the Ministry of Health to provide services through intersectoral collaboration, multi-sectoral approach, as well as community participation. So here, I think something's already going on. As far as I am aware, that I think Ministry of Health is already working closely with many of the CSOs and KPOs, where I think there is a MOU being signed, And the KP or key population organizations, there's basically organizations, CSOs formed of the key populations. They work closely with the Ministry of Health in implementing many of the HIV-related activities. So that is, I think, already there where community participation, engagement, community engagement in provision of health services. Now the latest one, I think, the National Strategic Plan for the HIV/AIDS and the HIV/AIDS and STI program at the Ministry of Health, I think they have now already finalized and adopted the National Strategic Plan 4, which is from 2023 to 2028. So this plan actually, because I also had an opportunity to give my points review this document. So I think this document specifically mentions many areas where I think there is a provision for providing services to the key population. I think it's basically focusing on accessibility to services. Like when you talk about accessibility, I think there will be more interaction between the health service provider as well as the key population. In terms of providing, just to give an example, female condoms, lubricants for MSMs. Then also there's provision also flexi time. Okay, I think some of the findings from the survey, I think has found out that, okay, there's not, that for example, female sex workers, if they want to access the HIV related services, I think their time, because they work in odd hours, the timing is different. And for some of these KPs, coming to the health facilities, it is awkward for them because like changing, the stigma, discrimination, all that. So they are going to open up, new areas, where they can have this access to services. But gaps, definitely there's gap is there. Gap, what I find is because even when I was in the system, I never knew about the challenges, of this key population. Because there's, I think, no evidences. But now evidence is coming, and also I think there should be more advocacy. Evidences should be there, and I think there will be more collaboration, coordination, and also advocacies, like what we are doing today. So I've been involved in a few of these advocacies in the past. So I think it's a good opportunity for people to learn, So this advocacy should be not once, but I think it should be repeated, and also it should go at policy level, the managers, and our health professionals at each level. I think that will give an opportunity, so better understanding of the needs of the key population. Other one, I think we found out when we interact with our health professionals, but I think many of our health professionals are not aware of what is the, this healthcare needs of these key populations.
Yes.
Okay, once a transgender person comes to the hospital, what is their, I think some of the TZs were telling us, informal discussion, they were telling me that, okay, we need hormonal therapies, but when I go to the hospital, because maybe our health professionals are not trained. Yes. So these are the, I think, firstly, I think our health professionals need to know the needs, healthcare needs of this key population. Yes. Okay, apart from this HIV services. And other one is also, I think there's also now some, I believe, there's discussion going on that including this into the pre-service curriculum of our graduates at FNPS as well as the undergraduate. So I think this is a good start, and I'm sure as days goes by, I think that there'll be more better understanding between the key population and the health service providers. Yes, thank you.
Yes, thank you so much, Doctor, because I think you touched on a very important aspect of understanding accessibility. Even as a sort of unordained in healthcare services, when I look at accessibility, the first thing that comes to mind is perhaps we have to construct a hospital, right, or a health unit where there will be access. But as you pointed out rightly, key population, they have their unique characteristics. They have unique circumstances that compel them to like for example you mentioned female sex workers, for example, they have their circumstances, for example, like their odd working hours, as you mentioned, prohibit them from accessing healthcare. So having a deeper understanding, I think, as you mentioned, plays a very important role, and key population organizations such as Pride Bhutan that Tenzin runs, collaboration is very important. But you also mentioned that about training the health workers, and I think this is our opportune time to jump to our panelist who represents an academic institution. So, Doctor, my question for you is that as a pediatric surgeon and educator, what role do you think academic institutions play in creating a more inclusive and compassionate healthcare environment for HIV prevention and treatment? And if you could also highlight on what sort of training programs, right, are in place right now and what are in the pipeline. Yes.
Okay, good evening once again. Thank you very much for the question. So this question and the answer is a timeless challenge for all of us, those who are sitting here, right? As health workers, our aim is not to make the life of our patients, our friends, not just less horrible. We want to make our lives of our patients more wonderful. And if I may answer the question by looking through the lens of redesigning our academic institutions, redesigning our the way we train our trainees, like our friends who are sitting here. So yesterday, I went to the ICU to see my dying uncle. So we are talking about the healthcare environment. So the room is something like this, yes, with floodlit lights. Ventilators are beeping, making strange sounds. With tubes going inside your throat, nose, everywhere. Lines going in and out. But my sick uncle was like, he's more sick of the environment than of the disease. He just wants to get out of the ICU and maybe have a peaceful death. He is still struggling with his life. So these are the questions that our clients ask us. So I was thinking, like, in line with this question, why is this happening? Maybe just for a while, our healthcare system is badly designed. When I was a student, and I believe when Sir was a medical student, we have been trained in a disease care model of healthcare. We are just concentrated only on the disease. Suppose when we are talking about HIV/AIDS today, if I go there as a patient and says HIV, I'm just that HIV thing. I'm not a karma sharap. I have no identity as my own. But in reality, life is different. So if we have a chance, maybe we have to redesign. And the world is already thinking of having a paradigm shift from this disease-centered model of care to a more human-centered, to a more patient-centered. And believe me, we will reach there one day. You all are going to do that. Maybe for Sir and us, it's a big question mark. Then another way of making our institutions more conducive, more generative, let's say more playful in our partnership. As an academic institution, we can have a good curriculum design, curriculum development. And when we talk about key population, HIV, think our students, our future healthcare providers should be educated in which they have a comprehensive knowledge of what HIV really is. What are their different needs, unique needs, so we are talking about. So they have their unique needs. They are not like any other patient who has suffered from a road traffic accident or something. So I think our students should get those insights, get those knowledge, everything when they are in the student. And if I may, what I'm very passionate about is what is now called interprofessional education. So some of you are nurses, some of us are doctors, there are technicians, there are counselors who are involved in taking care of this type of patients. What is happening now is I am taught in one room Our counselors are taught in another room. Our nurses who take care of our patients 24 hours a day, they are taught in another room. So the new concept which we would like to embrace, and which with our president is here, which we are trying to inculcate into our curriculum, is something called interprofessional education, where from day one our health professionals work together and learn together and how to work together. Right now what's happening, a doctor from India, say, like, comes, a nurse from, say, Bangladesh comes, and they have their own ideas, they have different ways of thinking, and so there is a big cultural or any other something of like that clashes happening. So our healthcare is not being very conducive, more generative. So these are some of the issues that healthcare institutions can help. Maybe the most important thing is how we design our curriculum, and not the curriculum which is there, let's say, virtually. It should be followed up. So we have I believe that we learn by doing things, and not, most of us, what happens, we say something and do some other thing. So I think if we can change that mindset, we will make great progress. That's what I honestly feel. Thank you.
Yes, Doctor, thank you. Thank you for your thoughts on palliative care. You mentioned that there's a great need to look at end-of-life treatment, right? But also healthcare is about treating the living, breathing, feeling human beings, and much of the approach right now, as you mentioned, in the global healthcare is about focusing on disease first, disease treatment. So I understand how Bhutan can even champion that, and wearing the entrepreneurial hat, I think that can be a very interesting sort of paradigm shift in healthcare that Bhutan can actually champion. The brand resonance is also there. You mentioned about academic institutions, redesigning Bhutan context, redesigning curriculum with Bhutan context. A little bit on how that should involve key population organizations like what the Tenzin is leading, and other stakeholders as well.
So when I talk about a comprehensive curriculum, so it's not only including the science. So one very important idea and concept I found here is our spiritual attachments, or spiritual values, or beliefs. This should also be taught to our students. Then very important concept is mental health. So I believe, like the example of my uncle who is there in ICU, the disease is not killing them, but the societal pressures. More than the disease, he is thinking about. My uncle is not a very rich man, but the rich man, he is thinking about how his wealth will be distributed among his sons. So there are so many other things that is going inside the brain of a sick man. Even a HIV or a key population member, they also have these mental issues. I think this mental issue is really more important than the physical aspects of our care. And in response to sir's questions about how to involve like people who are involved directly in the key population care, so that's where the concept of interprofessional education might take care of it. I would like to think it in that way. So they are also involved, how they can contribute to everyone's care. Okay, thank you.
Doctor, I think in many ways the first part of our discussion has a lot of, it's very somber, right? Because we're talking about such a very important, deep-rooted issue. So, however, what you just said about having this new outlook on how we provide healthcare for our population, I think is very hopeful. And as a young person myself, when we look at what's happening in the country at large with, say, the Gelfu Mindfulness City, I think that place is being designed from little that we learned during the Innovation Forum. it's being designed to be that new approach thinking that Bhutan is going to champion. So if our academia is thinking like that, then I think there's a lot of alignment. So I just wanted to point that out. Going to Tenzin, you mentioned a lot about stigma and discrimination, right? Being key barriers for people living with HIV. Can you share how, we would like to request you, if it's all right, to share about some of the ways stigma specifically impacts, I'm sure you have come across many people when you were, implementing a lot of these projects led by your organization. So how, give us examples so that we can connect.
Lasla. So it's just a common sense, common sense that when the environment of a place, or when you don't like somebody who is very toxic, you usually do not want to approach that person or place. It's very simple as that when it comes to stigma and discrimination. So you see, when there are stigma and discrimination from one facility, people usually fear of going to that facility and would not. So when we are talking about this, let's say we are talking about like building a facility for where key population can go. So that is also something that we have thought about, but then we were like, oh, if we have this kind of facility, people will know that you are from key population and this will be an identifier for you, then people would not go. So that's why it's very complex when you work with the key population. So when you have this kind of stigma, discrimination, I'm not saying that there has to be stigma and discrimination, because you are working with key population who are very sensitive about their status and their identity. So for an example, I think we had few incidences from hospitals whereby our transgender men population were actually harassed in a way, and then since we are very close-knit community and people usually knows everyone knows one another, so they were like, okay, this happened to me, I think you should not go to that facility. Like I think the doctor said like, so that happened in one of the facilities. And then they were like, when we were in the conference and meeting, they shared this kind of incidences has happened to us, and then it usually puts fear to other people in Angola, even though it has not happened to you, but the fear of being okay, might happen to me, and then from there what we actually saw was people were really reluctant to go to the health services. So that is also true with people living with HIV, because if I was living with HIV, I will fear that someone might know about my status. Hospital hospital first of all, that is a question that my neighbor, my families, my peers might ask. So that is always there. But if, in addition to that, if you have a health facility whereby you do not trust the doctors, then it's going to be very difficult for them to access services and actually to adhere to their medications. I think that's why I think when it comes to stigma and discrimination, the reason why I said that it is one of the biggest challenges is that is why.
So Tenzin, you said that it's logical that people naturally stay away from what's toxic, but I'm sure you agree that people living with HIV are not toxic, right? They're living with a disease, and just like any other patient, the care that they are given should be compassionate, designed compassionately. And thank you so much for the work that you're doing. And the people who are watching this right now, I'm looking at 477 virtual audience. So that's incredible. And I think this forum right now, we should take the opportunity to say, right, that this stigma we should collectively address. So I'll go to Dr. Karma. As Tenzin mentioned, stigma and limited awareness about HIV remains a huge issue. And if this is happening in urban places like Thimbu, right? What about rural areas where the information awareness is I'm guessing low. So like what should we do for that?
So before I answer your question correctly, let us remind ourselves that the HIV/AIDS epidemic has come in waves, and now actually the HIV epidemic itself has gone down with time, and the second wave was the AIDS epidemic. And people have responded to it collectively and individually, but now the third epidemic is the stigma and discrimination. People have been able to control HIV virus to a certain extent. People have been able to treat the AIDS epidemic. They have found treatment. They have been healed, though maybe some of them are not cured. But now the toughest, let's call it, enemy in front of us is the stigma and discrimination. That is what is, maybe Tenzin will agree, bothering us more than the virus and then the disease. So now the question is, not like exactly a question. I feel now it has become a social issue more than that like disease. It is more a social issue. It is more a mental issue. So let me introduce you to one author whom I like reading his books. So his name is Abraham Varghese. He is a superstar doctor in USA. And he has written many books about HIV/AIDS. One particular book which has stuck with me is something called A Doctor Story about AIDS. So it was in the late 1984, 85, when in USA the HIV virus and AIDS epidemic started. And when there was no cure, there was no drugs to treat, and he was overwhelmed by people dying in front of him because of the AIDS. So in that book he writes a story about a young man, a gay man, who comes to him to get himself checked, and he finds that the HIV, that man is positive. He has turned positive. So he has to break the news that, okay, Jack or Rosie, you are now HIV positive. And in that experience, Abraham Varghese noticed that the boy was very disturbed. So he said, please come back tomorrow. And Abraham Varghese thought that he could give he hoped in his heart that he could give some hope to this young man. But next day, he learned that this young man had gone to the local nightclub, and let's say he had engineered a shootout with the police. He couldn't kill himself, but he took out a gun and pointed to the police. And the policeman, in self-defense, shot him dead. So this story again re-emphasizes and tells us that HIV and AIDS, and maybe even not the virus, it doesn't kill us. I just want to re-emphasize that it is the stigma, whether it is real or whether it is perceived. So there is a big stigma. And it will really take all of us hands together to fight this stigma. Thank you.
Thank you, doctor. I really liked the analogy that you gave of the HIV epidemic coming in waves. So I'm not an expert, but what I'm hearing from you is that the number of HIV patients rises, right? And the country sort of tries to address that immediately. Then the number sort of plateaus and doesn't rise, but because there's a lot of stigma and around this topic, the number sort of declines, but we cannot eliminate it. So the response is not successful because the society has not sort of accepted that as fully as a problem. The collective effort is not recognized, so it sort of picks up again and it comes in waves. Okay, that's a fantastic visualization. Thank you so much. I really believe that when we discuss development of our nation, we talk so much about the youth demographic, the young people being the drivers and movers, but we also have a wealth of wise elders as well. And with that, I sort of look at our most experienced panelists. So to show, with your experience, I would like to tap into your wisdom. With your experience now, like we see that we recognize the problem. So now the first step in finding the solution is there. Now, from your perspective, how can we get around this problem? How can we ensure that once we plateau this graph, that it remains, that it falls down and does not rise back up?
So it's regarding the stigma discrimination, no? Anyway, I think yes, I also got to see some reports, especially from the CLM studies, no, that stigma discrimination do take place in the health facilities. And also, as one of the health professionals, is very unfortunate that health center is supposed to provide compassionate care, and this stigma discrimination, and that I think we cannot deny. But I think we cannot just leave it like that also. So it's very encouraging to note, firstly, that the key populations, they have the CLM, complaint monitoring system in place. I think that should be continued. And also, I think I'm Tenzing and myself were involved in the last couple of years, disseminating this finding of the CLM study to our health professionals. So then from there, we realized that many of our health professionals were not aware that whatever they were doing was stigma and taken as stigma and discrimination. And also, so that then when we really, because JW also we had some awareness, counseling and other hospitals more. So there our health professionals were telling, we didn't know that this was, I think they thought it was as a part of thing. Many of them didn't know that it was stigma and discrimination. And also now when you really, I think, talk to them, these are what is happening. So they were aware, I'm concerned. So that means what I want to emphasize here is that the CLM finding, I think it has to be, I think it's done 6 monthly or whatever more. I think it has to be continued. CLM study has to be continued as continual monitoring, and that whatever data information you gather from that CLM, that it has to be shared and disseminated to our health professionals at each level. Other is I'm also aware of that we have also developed a system called feedback mechanism, where, and this is a very formalized system of giving feedback by the KPs on the health service, type of services they get. So I think because even the Ministry of Health departments were involved, and we had a meeting with the NMS and all that. So I think this system has been put in place, and we also had the opportunity of training all the QA focal persons in the districts. So now this feedback mechanism has to be institutionalized. Because I think there is where all the findings lie. Because key populations, when they go to the hospital, whatever experience, whether it's good experience or bad experience, I think they have to share in this feedback mechanism immediately. So then those data I think has to be collected, and then I think it has to be shared. And I think that it has to become formal, because I think it will go right up to the president of the NMS or the director or secretary at the ministry level. So I think that it has been formalized in such a way. So if that feedback mechanism should be continued, strengthened, and make it formal. So I think that will give an opportunity for all this more interaction between the findings of this KKP explaining the health facilities and they're sharing the information with the health professionals. And other thing is, I think we also know that we health professionals are all governed by the Medical Council rules and regulations. No? So that also actually now we are professionally, it is professional code of conduct, they say. So as a health professional, we are not supposed to stigma and discrimination is against our code of conduct and ethics. So it's also important, I think, our health professionals should be made aware of this code of conduct as per the Medical Council regulations, rules and regulations. Other thing is when you talk of stigma and discrimination, I think the experience from other countries, sometimes I think it's also multi-sectoral. Just health taking care of the stigma and discrimination may not solve the problem. Because sometimes the other sectors are legal, there's the police and all that, and other general society, I think stigma and discrimination against this key population, I think has to be dealt at the larger level, at the multi-sectoral level. So thank you, that's it, I think. Thank you.
Lester, thank you so much, Doctor. I fully agree with you that the need for data is very important, and you mentioned two very important ways we are collecting data on this front, and the need to continue collecting data. You cannot make informed decisions without data. I think long gone are the times where we make decisions saying so I agree with you that we focus on that data, and I think we have here in audience so many aspiring future healthcare providers. So going back to Dr. Karmala, how can training programs be improved to ensure that future health workers, health providers are better equipped to serve these marginalized communities and overcome barriers related to HIV care? You've already touched on it, but
yeah. So when we think about training programs, when I was young, I wanted to go to places like America to learn things, right? But after all these years of practice, I have learned a very important point. I feel it is very important to us. So our greatest teachers, our timeless teachers, are our own patients. I have learned more from my patients than from any textbooks, than from any universities. Our patients, especially for young healthcare workers who are students, our patients have taught us how to listen to them. Our patients have taught us how to talk to them. Their pain, their fear, their uncertainty has taught us and has taught humanity to how to respond to them. So the first thing I want to remind all of us is that our teachers are right in front of us. That is our priceless teachers, timeless teachers. You don't have to go anywhere to study about how to take care of our key populations. They are going to teach us. So that is number one point which I want to tell my young friends. Everything is in front of us. So all we have to do is to go and take the opportunity. Another point, so our training programs, I believe, is multifaceted. I think one of us mentioned it is not a one-man show, it is a teamwork. So similarly, our training programs should include a deep understanding of the HIV disease, the HIV virus, and hopefully how we can tackle the stigma and discrimination associated with it. We have to understand and learn their unique challenges, and at the end of the day, our training programs should be designed in such a way that we get the skills, necessary tools to deal with it. And one very important point I would like to I've met with few of the professors here. We had some interactions. So in our medical education, I think in education, we talk about the 3 domains. So domains of the head, that is the theory part. Then again, we talk about the domains of the hand. That is what we do with our hands after our head tells our hands, that is the motor part. And the most important and the most difficult to teach and the most difficult to assess is the heart. So in simple terms, we call it 3H, the head, the hand, and the heart. So the emotional aspect of the patients, our own emotional feelings and our response to. So that is one part which our professors and our teachers should inculcate in our young students, our young future healthcare workers. So I think it's a big challenge for all of us. And one important concept is something that's called lifelong learning. So for all of us, learning never ends. Maybe it applies in general, but especially for health workers, it is a lifelong journey. The journey will never end. So as long as you are a healthcare worker, if you stop learning, if you stop studying, then I think we should question our own motivation, our own purposes in life. So just to re-emphasize this lifelong learning, I would like to quote, I have seen somewhere, I don't remember, I don't exactly know who said it, but it is nicely said that the illiterate of the future are not those who can't read and write, but those who cannot learn, unlearn, and relearn. Especially, as I said, in medical education, in healthcare workers, what was correct yesterday may not be correct today. The turnover time of knowledge is, if I remember correctly, it's now even 7 hours or something. So please correct it. I vaguely remember it is 7 hours or 7 days. Now I'm very confused. So the fourth point I would like to make, this will be the last one, is to use innovative caring methods. Like COVID-19 has taught us that telemedicine can be a very useful way to help us reach those rural populations, those people who are living high up in the mountains. Yes, we need internet, we need telecommunications, but I think these are easier things than for doctors and health workers to go there personally to take care of our people who need help high up in the mountains, in the rural areas, and those people who do not want to come to our healthcare facilities for so many reasons. Okay, thank you.
Thank you, Doctor. So whoever said that quote also, thank you, because I think that was a very important message. Before we move on to with the rest of the conversation, like I said earlier, a lot of people are joining us online. So this message, I think this is the camera. This is the message to people who are watching live. If you have any thoughts, questions, please go to the comment section and leave it. I'm currently viewing them as we speak, so that there will be more dimensions to our conversation. There's a very exciting development that I learned when I was preparing for this conversation about the existence of something called PrEP. now I found that to be a very exciting development, like, especially in our fight against this disease, and also, like, to save so many lives now. With the introduction of PrEP in Bhutan, this question is for Tenzin. Like, how do you think it will? What are your thoughts on this? How do you think it will improve lives? And while you're doing so, you can also share with us in this journey what may be some challenges that you foresee, or some challenges you've already encountered.
Nasla. So I think by this month or the mid of this month, we will be rolling out PrEP. I think lots of efforts has been put into just to bring this PrEP into the country. So when we say PrEP, it's not just about you going to hospital and then consulting your doctor and then just getting into medication just to prevent HIV. So it is much more than that. When it comes to PrEP, I believe it comes with a very comprehensive service package. You are talking about counseling. You are talking about prevention information and education for other STIs, and then you just basically have to eat PrEP, and then you have monthly checkups. So it's kind of a behavioral change thing that we do, especially. So that's why you see the PrEP is not just. That's why I say that PrEP is not just about eating a medication. So and then I think the second point would be, I think when you are talking about PrEP, it's also about taking charge of your own health, especially your sexual health. So it's supposed to be the intervention and service package is designed in such a way that you are more aware of your health. You tend to take care of your health much more than what you usually used to do. So it's like I said, it's just taking charge of your own, let's say, own sexual health on your hand. And the third would be, I think, when you say about PrEP, it's also talking about that this I have said it in another forums that we had, especially related to PrEP, is that it's not just about you, it's also about people who you love. Because I, as a person, it's not that Beni Semenba, unfortunate accidents might happen with me, because at the end of the day, I'm just a human being. I might just hook up with someone else. I might get drunk and have sexual intercourse with some other person. And that is something that my partner do not have to pay for my mistakes. And I believe when I say this, I believe that PrEP is not just about yourself, but also protecting your loved ones. And then when coming to the challenges, I see that community themselves is going to be very big challenges, because right now we are not advocating PrEP as HIV prevention method just for key population, but for all the population. Because when you say, oh, PrEP is for key population, MSM, TGW, TGM, sex workers, people who use drugs, that is going to be identifier. When a person sees you taking PrEP, they will say, oh, do you belong to key population? So it's going to add to already stigma that is already there. So I think that is key population themselves is going to be the biggest challenges. And one other thing that I can see is delivery of services. So certain policies usually do not allow us to let's say dispense PrEP by community organizations or peer outreach workers. You have to go to doctors, or you have to come for consultation for the doctors just to start your PrEP. Mm-hmm. And I think as a key population, I am really comfortable, because I've already decided to take PrEP, and I have also consulted with partners. For me, it's fine. For people who are in closet, because I see lots and lots of people who are gay, bisexual, but are not able to come out. So for them, it's going to be very difficult. So I think the delivery methodology really needs to be considered. I think when it comes to delivery of HIV services in general, I think community-led or based approaches really needs to be considered. I think That's where we are talking about when it comes to policy and everything. Yes.
Thank you so much. So, for the benefit of the audience who are not aware about what PrEP is, right? It is a way of substantially reducing the risk of preventing HIV infection by taking a pill every day, if you don't have HIV already, right? Doctors can correct me if I'm wrong. So, thank you so much, Tenzi, for mentioning the way, especially methodology, right, of how we do this rollout, and how society again plays a very important role in making sure that this miracle, this important development, is able to address this problem. Otherwise, again, we are back to square one. So I'll go to Dr. Bandutla. What steps do you think are needed to make PrEP more widely available and accessible, right, to those at high risk of HIV in Bhutan, but also, as Tenzin mentioned, to make sure that this rollout does not become an identifier for to again stigmatize this particular community. Like, what steps do you think we can we can take, especially again in rural areas?
Thank you. Firstly, I think as far as I understand this, PrEP in other countries is given to all people who are at high risk for HIV. But I think in Bhutan, I think in the first pilot phase, I think they are giving to the mainly the KPs, the transgender, female sex workers, and the MSM. So for that, I think for now with the experience in other countries, if they are PrEP, that intervention has to be successful and effective. I think it is both on part of the service provider as well as on the service recipient. Now for the service provider, I think it's very important that the person, whoever is providing services, health personnel, has to have a very good knowledge and understanding about what is PrEP, what is advantages and disadvantages and all that. And for the recipient, I think it's very important for that person to understand why, especially because compliance is very important. Whenever you put someone in PrEP, then compliance is very important. So that person should should be able to understand what are the indications, contraindications, risk, and compliance. And also with I think as per the, if you look at the publications on this PrEP, they also said that there should be one-to-one interaction between the health worker, the service provider, and the service recipient. It should be people-centered. That health workers should be able to take confidence of the person with whom he is. So there should be lots of interaction, And also interaction also should be on a very regular basis. So with that comes so many things, counseling and understanding and mutual respect for each other. So I think that interaction is very important. The other thing is now in terms of service delivery, because I think we are talking of accessibility. We have to make it accessible. But I believe in Bhutan now, because our primary healthcare services is well established. I think it has reached almost more than 95% of our basic health services has a coverage of more than 95% coverage with our basic health services. Yes. So our primary health services, our primary health centers can be used as a point for delivery of the services. I think that's what is already planned in the pilot phase also. That's what I was told. So I think we can use our existing. So we don't have to have a new system, because these primary health centers are already providing other preventive HIV-related services. They are providing condom and all that. Some of them are providing all HIV-related health services. So this PrEP should not be coming as a separate service. So it should be part of the our preventive health HIV-related preventive services, which has gone right from the National Referral Hospital right up to the basic health or primary health centers. So it should be provided as a package through that. So that way I think it will increase the accessibility. The other thing is also now I think many times I think you have to have this HIV testing done. So many of the primary health centers may not have these facilities, and sometimes you also need to test. I think starting PrEP and also during follow-up there are some laboratory tests to be done. So I think for that maybe if those services are not available at those health facilities, I think there should be a formal referral mechanism. Okay, not that please go and test this and come back. So not like that. formal referral system, so that that person is goes, and the person is followed up and comes back to the report. So I think this system, of course, there's already a referral system, but maybe you have to have more formal referral system for these people who are put on this PrEP. So I think that will take care of, I think, most of the, and also sometimes I also feel maybe I think that even the new NSP, the Ministry of Health Strategic Plan, also mentions that it's also important look for other opportunities where the services can be delivered. HISC is one, I think, no? So, and also now maybe you can also later on, maybe in the long run, you can also use the service of the KPOs. They are already providing some kind of services, and we know that if the KPs provide services to their own community, I think it's more acceptable when they have the reach and all these things. So in the long run, I think we can also use their own KPOs, or member of the KPOs, to provide these services to their own clients. So for now, maybe that's all I can think of.
Thank you, Doctor. Doctor, I would like to follow up with another question to you. As you know, throughout this discussion, what we are uncovering is that we should not be just focusing on HIV as a disease that we have to, tackle, but there are so many other factors unseen, not just by the general public, but also not seen by healthcare providers. So, if you could touch a little bit on the intersection between HIV as a disease and also other issues such as mental health, and how looking at this holistically will put us at a better position to address this problem.
I think here we are talking of. They say that ideal health system, should be resilient. So when you talk of this resilient health system, they say that a health system which is, able to accept or adapt to any health challenges. So having, like, for example, now if you look at our Bhutanese health system, I think our Bhutanese modern health system started somewhere in the 60s, and we have. So I think we also know that when our health system over time, when it was established, and our successive monarchs as well as the elected government, they have always focused on welfare of our citizens, in shaping our health services, health system. So because of that, I think we have been able to adapt to any new challenges. Just to give an example, because initially I think we are focusing more on communicable diseases. Then so our health system was focusing on taking care of the communicable diseases, immunization program, all these things. Then we are able to achieve many public health, make many public health achievements. Then slowly, then NCD came in, where I think we are also looking at how to now face this NCD. So we have to align our health system accordingly to the new challenges. Similarly, mental health now with the challenges of key populations. So we have to adapt our health system with the emerging challenges of the health. But how is that possible? So here I think we are looking at the health system structure. I think WHO has identified 6 building blocks of the health system. Yes, so I think you have to focus on all these 6 building blocks of the health system, and give importance to each system, each building blocks, so that your health system is resilient. So, like for example, during COVID-19 pandemic, I think we did very well, in terms of prevention, as well as in terms of management of the cases, as well as our vaccination campaign. So it was all because we are able to maintain our health system in a strong way. So if you go into health system, there are 6 building blocks. I think if you explain each building blocks, maybe it will take time. But overall, I think we have to have our health. Whenever you look at the health system, you have to look at all the 6 building blocks of the health system, so that your health system is resilient to the emerging challenges. So if you have, so then now new challenges, the KP challenges, key populations, then maybe we have the climate change, impact of climate change, and maybe we may have another pandemic coming. But these are all, I think, the emerging challenges. I think we need to be prepared. and we have to shape our health system so that they are able to take that shock and be resilient to the changing needs of the health system. Thank you.
Yes, thank you, Doctor, for advocating for the need for a resilient healthcare system. Dr. Karma, you have something to add?
So I just want to touch about when we were talking about PrEP. So is there anyone in this room who has not understood what PrEP means? Because it is an acronym.
Please explain, please explain. We'll learn more.
No, I just want to, if you all know, not the seniors, please, I'm sorry for asking this stupid question, but sometimes we do not know what we are talking about. Is there any students? It's okay not to know. We are here to come learn, discuss. PrEP committee. So, sir. Yeah, that's what. So they should understand what we are talking. So PrEP means, I'll just, in very short, it is pre-exposure prophylaxis. So it is just like these days you're getting flu vaccine in very simple terms. So for those of us who have not heard about PrEP, it is just like getting a vaccine. So here I believe people are taking some form of medication to prevent from oneself from getting contracting this HIV/AIDS virus, right? Okay, thank you.
Doctor, when you asked, like, is there any stupid person in this room who doesn't understand, my hand was, I was about to raise that, but then thankfully I got saved by the Jinda who said that they haven't touched it in the curriculum yet. So, okay. I go to Tenzila. Tenzi, given your experience engaging with stakeholders, right, with introduction, of this very important medicine, what sort of partnerships and collaborations do you think have proven to be successful, right? What has your journey been so far? And again, I think this relates very well with what Dr. Bandhu mentioned about creating a resilient healthcare system, right?
Nasla. So I think when it comes to PrEP introduction, I think we have so many stakeholders. We have people from National HIV/AIDS Control Program, then we have people from, I think, hospitals, pharmacy and all. I think that's when you look at the whole PrEP tag member. I'm also in the tag member, and then we have been engaging for a very long time. But when it comes to stakeholder engagement, I think what works is that you really need to keep them engaged and informed. Because first of all, you do not want a stakeholder who is very, let's say, not much engaged. That would just hamper your progress. Then you would not also want to have a stakeholder who is not informed. That's why I said you really need to keep your stakeholders informed. Because you call them for a meeting and you say, what's this meeting for? And you tell them, okay, this is what we are trying to do, and your stakeholder is like blank, and then you are not in the same page. So you have to update and then all. I think that's why when we look at stakeholder engagement, I think what works is that you really need to keep them informed. And when it comes to HIV, key population, I don't think that health is just the stakeholders that we are really looking forward to. I think we really need to expand our stakeholders list. I'll give you an example. For an example, you see, when you are working for sex workers and people who use drugs, since most of them, their activities are criminalized, you will need people from legal backgrounds. Just like additionally for that, I can give you one example. Like Dr. Pandup mentioned about CLM, or community-led monitoring. So this year, when we did community-led monitoring, we had around 415 participants. So out of that, I think 53.3% or about 53 reported that they had to incur out-of-pocket expenses just to visit health services or healthcare centers. And of that 53.3 who reported that they spent out of their, they had out-of-pocket expenses, I think 69% of them stated that these expenditure were not affordable for them. So now you see, or this tells us that economic status or strength of a person also plays a vital role, whether a person really wants to access health services or not. That means we also have to now work with other agencies who are working for economic empowerment. So that's why I say we really need to look, when it comes to HIV, I think we really need to expand our vision and look at the different aspects of this HIV and key population the issues this regarding. Yes.
Thank you, Tenzin. Now we're going to break for question and answers. So there are many vibrant young people here. So this is your opportunity now to ask questions. You can just raise your hands so that we can pass the mics. Any questions from the audience? Lasla.
Good evening. So I would like to thank the panel for giving us this opportunity. I am a nurse. So of course by health policy, we as health workers have the obligation of maintaining confidentiality and privacy for the patients. But my question is now, what if the client has a behavior that threatens to the community? So what are the policies or legal things that is established so far now? The other one is, now how about disclosing the status of the patient within the family members? And another one, last one is the pre-exposure prophylaxis. Why is it only for the key population? Why not for the health worker as well? Thank you.
I'll try to answer. Maybe can supplement. Firstly, PrEP. Why it is only for the. Now, if you see the HIV epidemic, how it is, moving globally, as well as if you see our national statistics, now HIV epidemic is getting concentrated among the key populations, globally as well as even in our data source, So as a startup, I think it's important that we focus on the key population. Okay, so we are giving to the PrEP to the key population. That's in the first place. The second place, I think then other one is also the key population, also the people using drugs. I think this is in the second phase. Okay, so then also later on, I think it will also depend on the risk factors. What is your risk factors of getting HIV? No? Okay, but for example, if you are focusing on female sex workers, they have high risk. But then we have to also focus on the client of female sex workers, who are the close clients of these female sex workers. It's done like that. So basically, I think now first time they are focusing on this KPs is because our HIV epidemic is getting concentrated among the key population. Okay, so but I think slowly, maybe it will be given to everybody also, who knows. But I think you have to firstly depend on risk factors, high risk population. Okay, that is the, I think, justification. Now regarding this confidentiality and all that, because I was also in the medical council for about 4 or 5 years, and also recently I was in the districts. I was asked to train our CMOs and DHOs, DPHOs on hospital admission and management. There also we discussed about this confidentiality. So they say that okay, if it's going to now that is going to have public health risk. That for example, we are also giving an example of pulmonary poison tuberculosis, and we also had a issue earlier, long time back. Somebody is pulmonary TB positive, but he is worried that if he tells his diagnosis to his employer, then employer may ask him to leave the job. That was the issue. Then he has requested the doctor not to tell his diagnosis to the employer. That issue came to the medical council. But here, I think here we are looking at the public health risk. If you ask him to continue working there, probably he will spread the diseases. So I think what we did was we talked with the employer
Okay, it was implied, okay, this disease is preventable, but we'll give him leave for so many days and we'll put him back in the job only after he has cured. Then, but he said continue to, later on he can continue to work, something like this, understanding, no? So HIV also same thing there. I think you have to look at the risk, no? Risk profile, no? How suppose if somebody is positive, probably now here we cannot say, okay, this person is positive, you don't have sex with him, that is wrong, you know. That's why we are talking of universal precaution, no? Okay, everybody has to. Now, whenever we say high risk behavior, don't have sex, you know, if you have sex with other, you use condoms, so these are things, no? I think so, I think you have to depend on case by case, no? I think we cannot say, okay, for this case we can, tell that diagnosis to everybody. For this case, I think you have to see and find out the risk. Now, for example, I think there's a couple, husband wife. So I think here it's very important. But I think you have to be, both has to be counseled properly. Husband is positive, means you have to counsel the wife nicely. Then I think that it needs lots of counseling and interaction between the that service provider and the client. Okay. So there's nothing, I think, of course, globally, if you see, many times, I think, even they have gone to the court, and if they have won this, because if there is public health risk, if there is public health risk, then this person lost the case because this person was spreading the disease, and there was public health risk. So I think here you have to see, I think you have to really analyze the risk, what is the public health risk, and how it can be dealt. So it is not like one solution for every issue, Okay, so I think that needs lots of, it has to be dealt by case. That's what my understanding is. Okay, so this way I think we are talking of confidentiality like that. Okay, and you have to look at the public health risk, no? Okay, so maybe I don't know whether anybody can add.
Any other questions? I will take, in the interest of time, only one question, last question. If there aren't any questions from the in-person audience, I would like to request all the panelists, if you have any parting sort of message, we'll provide briefly, if you have. So we'll begin with maybe Dr. Karmal.
Thank you. So lastly, I would like to tell that when I joined as a young medical officer, the metaphor of AIDS, HIV/AIDS, was that of shame, secrecy, and even a death sentence. So back in the early 2000s, I was posted in Samsi, and in Samsi town, we used to see the posters of skulls, spiders, scorpions, and that frightened us a lot. But these days, I think that metaphor that was traveling with AIDS has changed a bit. Maybe back in our memory, we still have those spiders and skulls haunting us. So the message I want to convey by this analogy is that we should have courage to invite our KPs to come forward, or maybe keeping the philosophy of medicine, which is grounded on altruism and social responsibility. What I have learned after having a discussion with Mr. Tenzin and few sessions I attended with Madam. So I think we should have the honesty and the courage to let them come and take treatment in our health facilities, which I try to say how we can make it more conducive, more palatable for them, or if things aren't that helpful, we can even go to the extent of like reaching the unreached population. I think it is a challenge for us, but as I said, we can do it. I think we should have faith in ourselves, and if God is on our side, we will take this battle, and hopefully we will win it. And I think it is the aim of the Ministry of Health, in line with the Sustainable Development Goals aim to eliminate this epidemic by 2000, I'm scared to mention, 2030. It looks very bleak, but it is a vision, and it is always good for us to have a vision so that we can travel on with our vision. I would like to thank you once again for giving me this opportunity.
Okay, I think we are all health professionals lah. Some are, I think, very senior, like Honorable President. I am also quite senior now. We also have young ones who will be soon joining the service. Now, over time, if you see that, I think our, especially the challenges for the health system has been changing. Now, societal needs are changing. There's demand for the different types of services, better services, And also that these challenges will continue, health system challenges. The patient's demand, the societal demand, as well as demand because of the epidemiological changes and diseases and all that. But I think we all should work towards making our health system resilient, so that anything comes, we should be always ready, So I mean, adapt to the challenges of the health system. Having said that, I think it's also important as professional. I think we should continue to promote compassionate care in our health facilities, so that every sick person enjoys come to the health facility and get treatment from our health workers. And other thing is, we also realize that communication is very important for health professional. So it's important that I think they say that if you communicate properly, I think certain percentage of diseases gets cured. So I think as a young health professionals, especially our students from this Faculty of Nursing and Public Health, I think you should inculcate this, communication skills, so that you are able to communicate well with your patients. Recently, I also trained some of our, district colleagues on communications and all that, why it is important. So having said that, anyway, thank you very much. I think it's been a pleasure for me to be here, and thank you, Save the Children, and also Loden Foundation for inviting us. So I think I had this kind of opportunity in the past also, and it has always been a great experience, to interacting with various groups of people. So thank you, and Tasdilala.
So for my closing remarks, what I'm going to about to say might sound that I'm blaming our victims or accusing our victims. But then I think when it comes to, since we are talking about changing health systems, making it inclusive of key population, I believe that it is a two-way approach. No matter how much we work to changing a system, if the community does not respond, I think that's not going to work either. I think communities really needs to be proactive. I will share you a very short incident. So 3 months back, I was facilitating one of the sessions in the forum. So we had so many, around 25 female sex workers in that forum, and I just asked, I was doing a session on community-led monitoring. I just asked them, how many of you have visited health facilities? And every 25 one of them raised their hand. And then my follow-up question was, how many of you have faced challenges or faced issues while you were visiting health facilities? Almost half of them put their hands down, and then 15 of them still raising their hands. And
again ask them, how many of you did something to address that challenges or issues you faced? And everyone was like, I think communities really need to realize that to solve a problem, I think you really need to be proactive. I know there are lots of barriers, but then at least we have a space whereby you can seek assistance from lots of KPOs, key population organizations. We have Laksam, CPA, Bright Bhutan, RPN, who can facilitate how to solve these issues. I think communities, what I really wanted to see was the communities really need to be proactive, especially when it comes to changing health system. I think if you don't, then this might happen to you today, might happen to someone else. I think we really need to think beyond yourself. Thus, thank you.
To end, I thought I will end with a story, but I had two stories in mind. So I was, as the panelists were giving their closing remarks, I was wondering which story should I share. But I think Tenzin helped me a lot, because I'm going to share a very interesting case study. At least it was interesting to me. So in Africa, they wanted to start immunization, right? And when they were doing this rollout of immunization, they found out that they were like, okay, when they were planning, they were like, okay, we're going to advertise, create awareness about this. So let's bring in the most popular celebrity, and we are going to create an ad, and then the number of people coming for immunization will increase. Much to their dismay, the number was nominal. The turnout that they expected wasn't there. Very confused. They said, okay, perhaps that celebrity was not famous enough, so let's call another famous celebrity. They created an ad similarly, spent a lot of money. Much to their dismay, again, the number of people coming to get immunization was still lower. Confused, they scratched their heads, didn't know what to do. Suddenly, the next day, they realized that the number of mothers bringing their children for immunization increased. So they thought perhaps it was because one of the celebrities worked. But turns out, when they did a little digging, one of the volunteers, UN volunteers, who was there helping, mothers give, who were there for immunization of their children, she was handing out a bag of lentils to the mothers, because when she was interacting with these mothers, she learned that a mother in that particular region had to make a decision between, should I go get immunization or should I go work and then feed my child? And she chose the latter. But because this volunteer was giving out small bags of lentils, the mother, no question, let's get immunization because I can still feed my child. Many a times this particular case study is shared to give values about how funds can be mobilized and small funds can have great impact. But what I learned from this particular case study was that it doesn't matter what role you play in the system. You can be a volunteer and still have such a huge impact. And with that, this is not the end of the conversation. I think this is a conversation that needs to happen in our classrooms, in our homes. And I hope that everyone here, including the ones watching, will take this conversation outside of this room. And on that note, thank you so much for being part of the 66th edition of Bhutan Dialogues. Kadishe.